Okay, for each chapter, nearly each chapter, we have self-assessment, and here we start with chapter 2. So chapter 2 was about pharmacological therapy and electroconvulsive therapy. So this is the question. Nurses ask for urgent review for a 24-year-old man who is a psychiatric inpatient and is hypertensive, tachycardic, and pyrexial. He is very drowsy and has rigid limbs. What action will most help distinguish between neuroleptic malignant syndrome and serotonin syndrome? Is it checking serum creatinine kinase levels, or looking at his prescription, checking his past medical history, formally assessing his cognition, or monitoring his condition over time? Let's check for these options. Although the two syndromes have features in common, they can nearly always be easily distinguished by actually medication history. So this is the answer, looking at his prescription. Clonus is another useful distinguishing factor, as it is present in serotonin syndrome but absent in neuroleptic malignant syndrome, where lead pipe rigidity is common. As we said before, serotonin goes with hyperactive symptoms, something like that, while neuroleptic malignant syndrome is something hypoactive, lead pipe rigidity and such. So, next question. Nurses ask for urgent review for a 24-year-old man who is a psychiatric inpatient and is hypertensive, tachycardic, and pyrexial. He is very drowsy and has rigid limbs. He was admitted a week ago with a first episode psychosis and has received large doses of haloperidol since. What is the most appropriate first management step? Is it A, discontinue all antipsychotics, B, work up for electroconvulsive therapy, C, give dantrolene, D, give bromocriptine, E, assess ABC? So this man is likely to be experiencing neuroleptic malignant syndrome. But what we should do, or must do actually in this case? ABC, so the answer is E. After ABC has been addressed, all antipsychotics should also be discontinued. The other answers are all possible treatment options actually, but none are first line before they are considered. Okay, he needs initial resuscitation, that's it, ABC. And then is likely to need transfer to general hospital or for investigation and monitoring and so on. So the answer is assess ABC. Question number 3. A 37-year-old woman with treatment-resistant schizophrenia is considering commencing clozapine. Okay. What should she be advised regarding the monitoring that is initially required? A, weekly blood pressure checks. B, weekly liver function tests. C, weekly full blood counts. D, weekly lipid profiles. E, weekly fasting glucose assays. And the answer is obvious. C, weekly full blood counts. Weekly full blood counts is the answer. Without monitoring, just under 3% of patients treated with clozapine develop neutropenia, low neutrophil count, and just under 1% develop a granulocytosis, which is negligible neutrophil count. This is most likely to occur early in treatment actually. Therefore, weekly full blood count are advised initially. As for all antipsychotics, she will also require regular checks for blood pressure, liver function, lipid profile, and glucose. These parameters should be checked every 1 to 3 months initially, then annually, so it's not weekly. But firstly, we should do weekly full blood counts, and we continue to monitor other factors. Okay. Let's go to another question about that. A 45-year-old woman has recently started phenelzine. She is out for lunch with her friend, who is a doctor. She asks her friend what she can eat from the menu. A. Broccoli and Stilton soup. B. Pickled herring on a bed of salad. C. Marmite and sesame toast. D. Smoked mozzarella fat. E. Egg mayonnaise toasty. Let's start them one by one. Actually, I don't know, but still, she cannot eat the first one. Pickled herring, she cannot eat that. Marmite and sesame toast. Marmite and marmite and sesame toast. I don't know. Marmite. I'm not sure about that, so I would. So the answer is E. The answer is E. I will not go to details because I don't know about that. Anyways, let's go to the last question for the multiple choice questions. A 37-year-old woman who takes lithium for bipolar affective disorder has recently completed a course of ibuprofen for knee injury. She now feels very tired and weak. She is unsteady on her feet and has a coarse tremor. A random lithium level is assessed. What's the lowest result that would strongly suggest her symptoms are due to lithium toxicity? Is it 0.2, 0.4, 0.8, 1, or 1.8? And of course the answer is 1.8, because her symptoms are consistent with lithium toxicity. And lithium toxicity is between the range of 1.5 to 2 millimole per liter. So that's the answer. And here we have extended matching questions. Each answer can be used once, more than once, or not at all. Of course, we are talking about Chapter 2, Pharmacological Therapy and Electroconvulsive Therapy. Here we have management of antipsychotic-induced extrapyramidal side effects. We have intramuscular procyclidine. These are some medications for extrapyramidal side effects. Intramuscular procyclidine, oral procyclidine, propranolol, stop anticholinergics, oral olanzapine, intramuscular haloperidol, resuscitation, baclofen, dantrolene, quinine. So these answers, for each of the following patients, select one best management option from the list above. So from this list, we you know, pick one answer, one appropriate answer for the followings. So, 1. A 22-year-old woman recently recommended on an antipsychotic who is pacing her bedroom and says she feels very restless. So, a female patient on antipsychotic, and this woman is probably experiencing akathisia, restless akathisia. This is hard to treat, but propranolol or benzodiazepine can help. Maybe the dose of antipsychotics may be reduced. Quinine can be used for restless leg syndrome when in bed. And we have other differentials for that. For example, she maybe have some agitation or something, but mostly she has akathisia. And akathisia is treated by propranolol. So the answer is propranolol. This is the most appropriate thing to do. Second case, a 22-year-old woman frequently commenced on an antipsychotic who is starting at the ceiling and clenching her jaw tightly. So, staring at the ceiling and clenching her jaw tightly, another side effect of antipsychotic. She is mostly have some kind of dystonia with oculogyric crisis. And clenching her teeth, this is, jaw clenching, this is trismus. So what we can do here is to give intramuscular procyclidine, anticholinergic, but intramuscular because, there's something with her jaw. So as we said, this woman is experiencing dystonia with an oculogyric crisis and teresmus. And of course, because her clenched jaw, we cannot use oral procyclidine. But in general, baclofen and dantrolene should be used for chronic spasticity. But now we may use intramuscular procyclidine. The third case, a 22-year-old woman recently commenced on an antipsychotic who is collapsed in her bedroom with a fast pulse, low blood pressure, reduced consciousness level, and stiff limbs. So again, another side effect of antipsychotics. So the patient here is acutely unwell. She needs, as we said before, ABC, and you may call, the emergency, the ambulance, the ambulance. Because the patient here may have neuroleptic malignant syndrome. Yes, we have other differentials, of course, substance intoxication or something, but so the first thing here to do is resuscitation. This is the answer, G, resuscitation. Okay, ABC, which means ABC. Okay. Yes, we can use dantrolene, but this is not an acute thing to do here. Another case, 4. A 26-year-old man who is commenced antipsychotics a month ago. His face shows little expression, and he does not swing his arms when he walks. He does not have a tremor, and his gait is not shuffling. Aha. So this man maybe has drug-induced Parkinsonism. In the early stages of Parkinsonism, the features are different to idiopathic Parkinsonism. So that's why you cannot see, for example, shuffling gait or tremors. You just have some, little expression, does not swing his arms when walks, these kind of things. So anticholinergics can help, but ideally the dose of antipsychotic would be reduced or an alternative antipsychotic trailed. But the answer here is oral procyclidine, you know, anticholinergic. Oral would help here. Okay. The fifth case. A 34-year-old man who has been on antipsychotics and regular procyclidine for over a decade. He makes frequent darting movements with his tongue, but seems unaware of this. So we are talking about chronic use of antipsychotics with, you know, face movements and tongue movements. This is tardive dyskinesia. So this man has tardive dyskinesia. This is hard to treat, but stopping anticholinergics, in this case procyclidine if the patient is taking procyclidine, and reducing or withdrawing antipsychotics if possible can help. So the answer here is stop anticholinergics. Stop anticholinergics. Okay. Let's go to another question. Mechanism of action of antidepressants. So we have these antidepressants: agomelatine, amitriptyline, bupropion, citalopram, duloxetine, meclobamide, and phenlazine. And for each of the next sentences, I would think, okay, let's just remember them. Agomelatine, this is for melatonin and, you know, and serotonergic. Amitriptyline, tricyclic. Bupropion, NDRI. Citalopram, you know, SSRI. Duloxetine, SNRI. Meclobamide, and phenlazine. Let's just say if there's any options. Here we have also pramipixole and reboxetine. Okay, so the question is, select the antidepressant whose mechanism is best described by the description below. So for each of the descriptions here, we choose the answer, the right answer. That's it. That's the point. So what is the drug that is described by this? 5-HT2C receptor antagonist and melatonin receptor agonist. The answer is easy here, agomelatine, because agomelatine is 5-HT2C receptor antagonist in addition to the agonism on melatonin 1 and melatonin 2 receptors. So the answer is this. Where is it? Agomelatine. Okay, let's get back to the questions. What's the drug that inhibits serotonin and noradrenaline reuptake pumps? Does not affect acetylcholine receptors. So why we are talking about this? Why it's not just you know, inhibit serotonin and noradrenaline just like that. Inhibit serotonin and noradrenaline reuptake pumps. Why we mention does not affect acetylcholine receptors? Because we are talking about something like, you know, here's the options. Duloxetine, yes, as SNRI, selective serotonin and norepinephrine reuptake inhibitor, like duloxetine and venlafaxine. Because tricyclics, like amitriptyline, for example, they also work like duloxetine. They block the serotonin and norepinephrine reuptake, but they also influence muscarinic, histaminergic, and alpha-adrenergic receptors. So that's why this part of the question, this sentence was important to answer the question properly. Does not affect acetylcholine receptors, while tricyclics has something to do, you know, with muscarinic receptors, cholinergic muscarinic receptors. Okay. The third option. Which drug inhibits serotonin and noradrenaline reuptake pumps also blocks acetylcholine receptors? So that's amitriptyline, of course, tricyclics, as we said before. So which drug has something to do with reversible inhibition of monoamine oxidase A? And the answer is meclobamide. It is the reversible inhibitor of monoamine oxidase, REMA. REMA, reversible inhibition of monoamine oxidase A. Which drug inhibits dopamine and noradrenaline reuptake pumps? And this is, of course, you know it. This is bupropion. Bupropion. Okay. Okay, that's it about chapter 2.